Today we'll be talking about the technical daily report, and also we want to share with you the estimation of the sentinel model that we have mentioned before. We want you to understand clearly what is the estimation of cases about when talking about the sentinel model, and we want to explain the functioning of this model that exists in Mexico since 2009 and how it can be of great help to the control of this pandemic. Oh, good evening, everyone. Our international state of affairs. As always, we will be showing the burden of disease of the past 14 days. Today we have it at 69%, which means the burden of disease globally is decreasing. This means the amount of people who are actively displaying the disease, who are actively displaying symptoms. And in relation as to which regions present the highest burden of disease, we still have, so to speak, a match between the European region and the Americas. They both are represented in a proportion of 45 to 46%. And in the case of the Americas, we still see an upward trend that will become the most visibly represented region in the upcoming days, as Europe slowly comes out of the pandemic. The second slide is the Mexican situation. We have to this day 3,181 confirmed cases. We also have over 9,000 negative cases, 17,000 suspect cases, and unfortunately 174 fatalities so far. And you can see at the map the distribution of the disease per state within the Mexican territory. The states that are marked with orange, of course, have a higher burden of disease, a higher number of infected cases than the green states, and of course the red states are the ones with the highest amount of cases. Here we can look at the same distribution, but taking into account the incidence rate, which is calculated taking into account the population of each state. So this number that we present here is the number of cases per 100,000 citizens in each state. Of course, Mexico City keeps leading the way, and now is also being joined on the statistic by some states in the northern part of the country. Here we have the age group distribution. Some of you requested this information yesterday. We can see that the most important burden of disease is displayed in young adults, and based on this data is that we would like to remind everyone that all of us are exposed to this risk, to the risk of being infected. All of us who haven't been infected yet, we are at risk of contracting the disease. So far, we've seen a distribution of basically all age groups are represented in the information regarding the confirmed infected cases, with the less represented group being the children, of course, and with the males having a slightly higher percentage than the females. Here we can look at the same age distribution, but taking into account the inpatient-outpatient relation. We can see how there is an increase in the number of patients over 65 who have had to be hospitalized. We have 70%, 71% of outpatients as compared to 29% of inpatients. And as we've said, these senior citizen groups have a higher risk not only of contracting the disease, but also of presenting more severe symptoms or complications once they get infected. The next slide we can see how this is the clinical state of patients at the moment of their admission at the hospital facilities. So we have 70% of outpatients, most of them. Stable hospitalized patients, we have 9.78%. Severe condition hospitalized patients, 15%. And intubated patients, we have 3.4%. 3.5 to round it up. And this matches the prediction that we've made about how the distribution would look eventually. Here we can look at the distribution per age group of deaths. And this is a different statistic because we can see a quite visible overrepresentation of senior citizens in the death age distribution, as well as an overrepresentation of males by 74%. Here we have the comorbidity stats, and the three leading causes of complications when being infected with this virus are still hypertension, diabetes, and obesity. But we also have other risk factors that are present, that are smoking, kidney failure, cardiovascular conditions, and similar diseases. Here we have the burden of fatalities per state, talking about the states where we have had, unfortunately, some fatalities, and we also have the lethality rate here. So we can see how these numbers vary according to each state, according to each circumstance. And it really depends on the amount of fatalities that have been reported, because when we have very few deaths, the variation in the lethality rate can be very constant. Here we have the mortality, which is a different statistic, and we can see how there are variations, and also as related to the population in each state. You can see the orange line, which is the mortality rate, and it also fluctuates from 0.5 to 0.02. Here we have the burden, the disease burden, the accumulated one, which is the epidemic curve, and we can see the highest point is the newest updated number, which is 3,181 cases. So of course we are accumulated an ever greater number of cases, and on the orange bars we can see the amount of newly confirmed cases per day as they have been presenting. So in both scenarios we are seeing an upward trend, even though we haven't quite reached an exponential growth rate, but we are looking at an upward trend. That would be today's technical report. Thank you.
Enseguida vamos a mostrar algunos datos complementarios que tienen que ver con otros elementos que informan sobre
Now we're gonna be presenting some complementary information for you to get a better grasp of the pandemic. The information that we need for the management of an epidemic, when you have such a phenomenon, you need to have information about how this epidemic is developing, how it's behaving. And this behavior has to do with a lot of elements that have to do with direct observation and also some elements that are inferred, using analytical models or reasoning tools. This information is transmitted from person to person, and now we've brought these slides to show in a very graphical way how this disease transmission mechanism actually works, because there's been some confusion regarding the way the virus is transmitted from one person to another. So we'll be showing that in a bit. We want to talk also about how fast the disease propagates, how extensively it propagates, who is most affected, and we will be talking about comorbidity in this regard. We also want to talk about what characteristics allow us to predict an unfavorable outcome, as well as what are the protocols and what is the response that is being provided by the health sector, how probable it is to have a death related to the disease, and that is the lethality rate, how probable it is to have COVID-19 as a cause of death, and that is the mortality rate. So what I want to express here is the number of cases. It's only the most minimal piece of information that you can have, but the relevant information is related to the relevant information to that number of cases, like age distribution, population, per state, etc. And that is the actual important information that will allow us to have a proper interpretation of the situation. I want to emphasize that the number itself is just a tiny piece of information. The important things are all the other elements that allow us to have a better analysis and then take better decisions. I want to put an example. When we had an increase of 2 or 3 cases per day, we had been experiencing a daily amount of new confirmed cases of 2 or 3 for several days, and then on March the 13th we jumped all the way to 12 as compared to previously having 3 or 4 daily. So this was sufficient for us to make a choice, and it was a choice that we have already prepared for, and we were expecting to see that turning point. And when we observed it, then we implemented and we took the decision that we have already prepared for. So the number of cases is only a piece of the information, but you need to have a wider array of elements in order to have better interpretations that lead to better decisions. Maybe you're thinking, well, 12 cases, that's too few, especially if we compare ourselves with other countries. At that moment, there were other countries like Italy or Spain that had thousands or hundreds of thousands or tens of thousands of cases. So you could think that wasn't that important, but no, it wasn't. It was very important, because we jumped from 3 or 4 cases to 12 cases. So we have been insisting on this, How can we know how to interpret this data? Because we trust on the analytical models that we have available, because there is a methodology in order to interpret this data. And when we are dealing with such phenomena, such as this one that is called, technically they're referred to as unmeasurable phenomena that cannot be measured, and there are many phenomena in the world that cannot be measured because they have such an extensive range of activity that it's just pointless to try to directly measure them. And we have compared the Sentinel vigilance program with polls. When you wanna have a better appreciation of a phenomenon within society, you can also refer to opinion polls. For example, Mexico has 127 or so million citizens. So if you poll the citizens on their opinions regarding a specific matter, you don't need to ask each of their opinions. You need to go and knock on the door of all those 127 million people. That would be an unnecessary waste of resources. So what you use is you design and implement a poll. Polls are instruments with a specific methodology that are widely used in many different social sciences, and basically you do a sampling of the population in a way that allows you to have a representative number of answers. So for example, if you interview 3,000, 4,000 or 5,000, and if you do it properly, you can have access to a representative sample of the totality of the Mexican population, while having, of course, a small margin for error, 2%, 3%. Another example, if you wanna know how much hemoglobin, the protein that gives blood its red color, and it's widely used in medicine. So if you want to know the levels of hemoglobin present in a person, you don't need to measure the concentration of this substance in the totality, in the 6 or 7 liters that are present in an individual. You don't need to do that, and also it would be impossible because you cannot drain someone out of all their blood in order to analyze all their blood. So how do you know the concentration of substances in general in blood? Well, you take a sample of 5 milliliters, not 6 liters, but 5 milliliters, and then you analyze that sample. And then you are observing directly a representative sample of a larger set. And you are assuming that the sample is representing that those 5 milliliters are representing those 6 liters that you want to study. So it is the same principle that is being applied to the Sentinel monitoring program. So I would like to talk about the interpretation of mortality according to two ways of identifying it, and both ways are used daily on our analysis. This is the epidemical curve, but this is specifically regarding the fatalities. And unfortunately, we've had 174 fatalities so far, COVID-19 related fatalities in Mexico. And here we see the daily registry day per day of how many people have lost their lives to COVID every day. And it is related to, it is compared to the day the symptoms began being displayed. So, of course, we can understand that from the moment the patient exhibits symptoms to the moment the patient unfortunately died, there is an amount of time. The average time is 9 days. So, on average, the people who have died so far from COVID have, it has taken them 9 days to go from the first symptoms to the moment of their death. The time frame is from the very first case, the very first fatality, to today, to April the 8th. The curve shows the accumulation of fatalities, and the little bars show the individual daily measurements. Naturally, of course, right now as we speak, we have people who have exhibited symptoms so far, but who haven't died, and some of them might die in the future. So, I mean, we hope that they won't die, but some of them might die. So, of course, we are a little bit behind in our information, and that is the only way it can be. The next graphic. This is how we take the same information and now we represent it taking into account the date of the death. This is 9 days later. And this curve has a different behavior. It looks a little steeper. This is the same data, but they are two different ways of representing it. The first one was the date of the beginning of the symptoms, and this one is representing the day the fatality occurred. So what we want to say is, it makes us really happy that society is allowed to express themselves, but not all information that is circulating is necessarily accurate. Sometimes people who write about this situation is not necessarily well informed on the topic. There are not always experts who are giving their opinions, but everyone has interesting things to share, and that is a good thing overall. There was a person, I don't remember who was insisting in recent days that of why were not we presenting mortality curves every day, and this was related to the insistence of why aren't we making enough tests. Well, here are the curves. Of course we represent the curves, and of course we are monitoring the mortality rates. This is all within the technical team information. What we can conclude from these curves is that the mortality curve has roughly the same behavior than the infection curve. Fortunately, so far we have a quite low lethality rate, which is 5.1%. Of course, these unfortunate 174 fatalities are a small number compared to the total amount of cases, which is over 3,000 now. So the behavior of this mortality curve is similar to the behavior of the infection curve. This is another resource of data that we have shared in previous occasions. This is the integrated monitoring of COVID. In order to have this integrated COVID-19 monitoring program, we have several elements that are working together. We have vigilance of detection of new confirmed cases that are confirmed through laboratory tests. For example, we also use the influenza type disease vigilance system that was implemented in Mexico when we had the influenza pandemic. And this we have laboratory vigilance, laboratory based vigilance, and the laboratory based vigilance program including COVID-19, includes 14 different viruses. And you may remember that we had these mapping operations in the beginning in order to know if this SARS-CoV-2 virus was circulating or not within different regions of the country. We also had the generalized conventional vigilance model, which is the traditional model for acute respiratory infection. That one's an older model that is still being used all around the world. This is a general vigilance model, which means that according to the law and according to the official Mexican norms, all health sector units have the obligation of notifying the relevant authority any cases of respiratory infection. That is not itself proof of an infection, is basically the symptoms that are usually related to infections. Now, the implementation of this sentinel model led to an error in appreciation by the public that persists in a lot of countries. And this perception is the perception that everything can be observed directly. And that is incorrect. The epidemiological science is based on the assumption that not everything is directly observable. However, in a lot of countries, people have the idea that the proper way of conducting oneself is to test everyone and to be very, very detailed in getting to in all of suspect cases, and that is the way to do it. But that is an incorrect appreciation, because nobody has the capacity to actually reach every case, and that is not the way the science works. The methodology that comes from epidemiological science is an estimation model that assumes that for each case that you are actually detecting, there is a number of cases that you are not detecting. So what you're seeing is not everything that there is. And there might be many reasons for this. Maybe the symptoms were not severe enough, so the person would get concerned about them. Maybe they showed up at the hospital, but they didn't get tested because of clinical reasons, because they got examined and then it got determined that the best way to handle their specific case was to send them home, for example. For example, the general recommendations are that if you're a young person who have no chronic diseases, no pre-existing conditions, you're not a pregnant woman, and you start to show symptoms, the recommendation is for you to go home and isolate yourself, because you will have a natural recovery process. So all of these people who have abided by our recommendations, they have helped us avoid crowding the waiting rooms at hospitals, at clinics, and crowding streets and public transportation. And of course, they won't be registered these cases, if they're at home, they won't be registered, right? But that's part of the model. That is contemplated. That phenomenon is contemplated on the vigilance model. So those countries who are not applying this logic, they are pretending that what they don't see doesn't exist. But that is not the case. And in Mexico, we are recognizing, because that is how reality works and that is how science works, we are recognizing that there are things that you don't see that do exist. Now, the following part is a little technical. I will do my best to express it in non so technical terms, but I think it is important that people have access to this information, because if you're only thinking about the number and you think the number is the only valid and the only important piece of information to deal with this epidemic, then you're not getting the full picture of how decisions are taken. Let's look at this graphic. I think some of you were asking about this proportion yesterday. I don't quite remember who. This is the distribution of confirmed cases per age group. And here we also have the relation between inpatients and outpatients, meaning patients with mild symptoms and patients in severe condition. And remember that before we entered phase 2, we had a fixed distribution of 20-80. 20 inpatients, 80% outpatients. And nowadays, we've been seeing some variation in this relation. Now we have almost a 70-30 distribution. Why is this? It is not because the disease is becoming more severe, but it is because we know perfectly, and this is coming from us because this is our recommendation, that these people who are fortunately 8 out of 10, they are not coming to seek personal medical treatment anymore. And that's fine, because clinically we do not need to have the confirmation, nor through lab, nor through examination, to make the proper recommendations, which is stay at home, drink a lot of water, have some sleep. If you have fever, take a fever medication, avoid all contact with your relatives, use a mask, and don't go out. These recommendations are fixed recommendations for all patients who are not at risk of showing any complications. So we'll be seeing some variation in this distribution, but it is important for us to understand the reasons, because when we were in phase 1, we didn't have these recommendations. So more people would go in person to medical units, and they would get registered on the statistic. And now they don't, because they stay at home. So please do take this into account when you're interpreting these numbers. Now this other slide is about something that is called endemic channels. Endemic means what, as in contrast with epidemic, endemic is what is normal for a population's health. And there are some endemic factors or endemic diseases that are endemic because they're always there. Colds, diarrheas, urinary problems, some skeleton related issues. There are a lot of conditions that are considered endemic, which means that they have not showed significant variation through time. Now this time frame is the weeks in a year, 1 to 52, and this is the amount of cases that are registered because they go personally to seek medical attention. The amount of the cases are represented in these areas, and the colors mean that a quarter of the people who have presented acute respiratory infections during the last 7 years in Mexico, they have presented these infections within these dates. This is what you see in green. 50% of the people have presented those infections on these dates, and that's the yellow part. Now, 3/4 have presented these infections on these dates, and this is the red zone. And as you can see, there are small variations, like in this area. For example, here in week 37, one quarter had it on week 37, and then we have an overlapping of the different distribution on the same week. Basically, this is the percentage of people that we expect to show symptoms of respiratory infectious disease in which periods of the year. So please do pay attention to the fact that these infections occur more frequently during winter, and then they exhibit a decrease. During summer, we have less cases, but we have colds in July. And then as the year gets less hot, they start to show an increase again. And this includes influenza, but also common cold and multiple respiratory infections. So this is useful to compare what we are expecting to occur to what is unexpected. And the yellow curve is what is happening right now in 2020. So the comparison is useful because we can identify something that is unexpected. When this blue line is higher, that means that we are experiencing a highest infection disease rate that in the previous 7 years. So we have seen this in this year. We had been seeing expected results, and then on week 12 it went up, and this is interesting. Why? Because week 12 ended Saturday 14th, and that was the day that we identified that we jumped from 3 or 4 newly confirmed cases to 12. And I came here and I gave a press conference on the fact that we went up to having 12 new cases in a day. And what difference does it make? 4 to 12? Well, because then this leads us to reinterpret the data. And we can see how it matches a variation in this phenomenon that comes from other health vigilance protocols. The following information is the same type of graph, but this is related to pneumonia. So, just as I guaranteed that coronavirus was going to arrive to Mexico, I guarantee that this is going to happen. So, even though we haven't seen a variation outside of the norm so far, I guarantee that we will see a variation, an upward trend out of the norm when talking about pneumonia. That is very clear that unfortunately there is no way of stopping the epidemic. There is only a way to decrease or mitigate its effects if we stay at home. So that is the interpretation. Finally, what day is it? What time is it? We have 20 minutes. So, yes, this registry is not, this pneumonia case registry is not associated with any test, any sort of test. And look at the amount we have. This is only 3/4. If we had been the complete cases, we would have like 7,500. Every year we have hundreds of thousands of pneumonias because of a wide variety of causes. Some of them are identified and a lot of them are not identified. It doesn't matter if you run all sorts of tests, you don't know the cause. Last slide. the raw numbers. Using the method that I've been explaining, and I would like to remind the public that journalists are very familiar with this method, within the sentinel vigilance model. Remember what I said about polls? We have a universe of over 100 million people, and we only have 3,000 people who were polled. Well, this is the same. In Mexico, we have 26,000 medical units, family medicine units, health centers in rural areas and city centers, hospitals. In total, we have 26,000. Within the Sentinel model, we have 375 medical units who are monitoring influenza. And now they have changed their name, and now they're called respiratory disease monitoring centers. And why did they change their name? Because now we incorporated COVID in the diseases that they are monitoring. So listen to what I'm saying. 375 units out of a universe of 26,000 units. Someone who doesn't know anything about epidemiology might think, how is it possible that we only have over 300 units out of 26,000? Well, because there is a methodology that is designed in order to ensure that this sampling is effective and this monitoring is effective. This vigilance model also contemplates aspects such as comorbidity, whether they are smokers, whether they have hypertension, if they were hospitalized for how long. It's a pretty diverse number of different information that is collected by this vigilance strategy. So I'll try to be simple in my explanation, or direct, when explaining this chart. Here we have the weeks of 2020, 1 to 13. That is the one that is currently happening. Here we have the acute respiratory infections, the pneumonias, and the influenzas. In the 375 monitoring medical units. And this is the number of cases that I directly observed of these diseases. And here we have, these are the ones that enter within the definition, within the case definition of influenza, which is virtually the same as the one for COVID. So here, so two different numbers, right? One of them, this one is only if they sneeze and they seek consultation, they enter in this statistic. And the other one is if they actually have all the characteristics that fit into the diagnosis model of COVID or influenza. And of course, it's a smaller number. So far, this information that we're giving, so far we have no laboratory test. Now on this column, here we have the laboratory test. And then we have the positivity index, which means out of the tests that were implemented, how many of them were positive for SARS-CoV-2 in this percentage. Remember that we've been presenting this percentage, and the percentage has been going up. Here we have the number of cases that came out positive. This is the number, this is the percentage. Finally, we have an element of quality control, which means how many tests were processed, which is different to how many tests came positive. We have processed almost 17,000 test in Mexico in the COVID-19 laboratory, in the coronavirus laboratory. And here we have the vigilance statistics of the two graphics that I presented. These are the 26,000. So if we multiply, we can know for each confirmed COVID case, how many cases are there in the population that I didn't get to see. And finally, we have this final number, 26,529 cases. So out of the 3,171 cases that we just informed, there are another cases that didn't reach consultation, but we can say with certainty that these cases exist. That's it. Oh, the last graphic. The final photograph. This is a public interest, generalized public interest. We're not talking about ignoring your friend or your relative or your neighbor. What we are referring to is that we wanna avoid these little droplets from falling on us, especially our nose, our eyes, our hands. There are large, medium, and small droplets. There are drops that are very heavy and they don't reach a very long distance. But there are some of them that are very light and they can go all the way 10 meters from where you are if I sneeze in this way. So this is what we want to avoid, and that's why we are promoting the two measures, the safe distance, because with the safe distance, this distance will allow you to be protected from the heavy drops. But also, if you're gonna sneeze, cover yourself with your elbow, because this will protect you from the heaviest drops, from the lightest drops that go at 10-meter distance. That's it. We're gonna have few time for questions. Let's begin. Little time. Yeah, we're not gonna have enough time. Look at the time. Thank you, Deputy Secretary. First of all, talking about this information that the Ministry of Health made public this afternoon, where you said that you do not recommend sanitization tunnels as the ones that we have been seeing all over the country. Can you talk about the function of these tunnels or the role of these tunnels in helping dealing with the pandemic? If they are not useful, what should the authorities do? Should they remove these tunnels, or should citizens avoid entering these tunnels? And talking about the sentinel model that you've been describing, how can we paraphrase this very technical class that you have given us to the general public? First of all, the tunnels. Yes, these tunnels started appearing even inside hospitals in Mexico City and in some public spaces, plazas and some public parks. And then we also saw them in some states in the north. If they weren't a hazard, we wouldn't have said anything. We would have just said, you're wasting your money. But they are a hazard. The techniques of sanitization of public spaces or of people who go to public spaces, they have very specific technical characteristics. And these tunnels, if you haven't seen them, they are literally gigantic tunnels through which a person can walk. They have more or less 3 or 2 meters of diameter, and they have some tiny tubes through which they apply some disinfectant or some antibacterial substance. So the person will go through the tunnel and then they will be sprinkled with this antibacterial solution. These tunnels are usually designed to be operating within a controlled environment when the people who go through these tunnels have special protection, eye protection, nostril protection, face protection, because through this process they could have eye irritation or face irritation coming from this substance. But if we are assuming that there is a infected patient that is going through this tunnel, well, what is going to occur is that as the person breathes, these infected particles are going to be dispersing through the air. And if the sanitization time is not controlled, and depending on the concentration of the sanitizing substance, it could be that this person will go through the tunnel and the time is not enough for them to become disinfected, so to speak. And also, if the time is way too long, this could be prejudicial, and then it could add to the infection of this disease. So that's why we said they are only designed to be implemented under specific circumstances. They shouldn't be just appearing all over the country. Now, about summing up the conference that I've given today, I want to say this: Mexico utilizes a proven and controlled method of vigilance that is very efficient, that was established in Mexico in 2006, and the World Health Organization and the Pan American Health Organization were involved in the design and implementation of this process, which is the sentinel model. And through the past years, the methods and implementation of this model have been improved and have been amplified. This model allows us to have a very accurate measurement of how the epidemic is behaving in Mexico, and allows us to make informed decisions on the measures that are more effective when dealing with this pandemic. Also, this method allows us to see the epidemic for what it is, and not only what we see. We estimate 26,000 cases, roughly. And someone could say, oh, but that means that Mexico has a way bigger number of cases than other Latin American countries. No, that is incorrect. We are estimating that we have over 3,000 observed cases, and we estimate to have 26,000 cases. In other countries, to have the total number, they would have to do the estimation of how many cases they actually have, and not only the ones that they have observed. So they would have to multiply the current number of confirmed cases by a factor of 10, depending on the situation of each country. So, for example, a country that has 10 cases with a correction factor that the one we are using would have 3 million cases. So what we are observing represents 10 or 12 times more of what we have. So, considering that 26,000 is the final estimation, so no, I think you got it backwards. The people who can be directly observed are over 30,000, but each of those observed confirmed cases represent roughly 10 people who, for one reason or another, couldn't go to consultation or was not confirmed as a positive case. But we could see that we have 8 times. The factor is 8 times. What we are observing, the epidemic is 8 times larger. But this doesn't change the measurements. And that is why I wanted to make it very clear that when we reached 12 cases per day, that was enough for us to implement the massive mitigation measures. So one number is the confirmed cases, and the other one is the mitigation is the estimated cases. So these estimated cases, can we can we assume that they are in isolation? No, they are not in isolation, because if we had seen them, we would have put them in isolation. But thank you for the question. Remember what we said in phase 1, for phase 1 and phase 2. In the beginning, we have a very manageable reality because you have a very small number of cases. So the ones that you detect, you put them in isolations. In isolation, but we said from the very beginning that the day would come in which we have so many cases that it's pointless to try to directly put, specifically put each of them in isolation. So that's why we adopted the massive mitigation measures, which is addressing the general population and saying stay home, stay home. No, tomorrow we can talk about more about mortality if you want. What you presented is very complex. There are a lot of questions. So if you need to end the live streaming in 2 minutes, end it and then we can continue. Can we continue? Why not? I don't know why. We can. For me, the public won't be hearing our conversation, but I think it is reasonable. We can give you some extra minutes. So last on air question, and then we will continue off air. The Citizen Council for HIV of Mexico City sent a letter to President Obrador in which they expressed their concern for the suspension of several services that are related to HIV. And they said that this could affect the HIV patients in the city. Do you have a response to this? And also these charts that you have shown us, the increasing number of infected patients, are within the expected numbers or they differ in any way? It is the same as we estimated originally, and it is the same that we had expected. And it doesn't matter if you're talking about these confirmed cases or these estimated cases that are 8 times more numerous, the trend is the same. I haven't read the letter you're talking about. I am very respectful and I admire greatly the Citizen Council for the Prevention of HIV in Mexico City. They've been great allies of us in the past, and of course I want to know what they have to say, and I want to read their concerns. So I will read the letter, and tomorrow we can continue. Yes, this epidemiological information is not national security classified, right? No, it is not. Okay, so the question is, the graphs that you had presented to us, half of this information comes from the positive case information, and the other half, we don't have access to this information. We don't know where these patients are hospitalized. We don't know how many people are infected, which means we have to only deal with the information of the charts that you are providing. So we would like to make this information public because we need this information. Yes, no problem. Another point is related to a change in the technical report. On Sunday, we have 5 countries that were identified as active countries within the context of the transmission of this disease. We have 5 active countries in the list, in the official list on Sunday, and then the next day we have 30 countries. So I don't understand. Thank you very much for your demand of access to information, of information being public. I want to let you know, if you are asking for this, if you ask for this information, we will of course give you the information. We try to synthesize and we have to summarize because not everyone has the time or the disposition to get in depth into the technical details, but I'm more than happy to share all of this information with the public. So, to the degree that you ask more elaborate, more specific questions and not repeat the same questions over and over again, then we will, of course, be answering these questions and providing public access to this information. The, close, the closing time is 1 p.m. They made this information available from 7 to 12, and we would like to broaden that window of access to information. The difference regarding your first question of the variation of the number of active countries within the protocol, it is related to the fact that we transitioned from an online data collection system to the Sentinel system of collection of data. And through this data collection system, we will be monitoring not only COVID, but also at the same time other infectious diseases that are of interest to the country. So this, because we transitioned between one system and the other, from one platform to the other, this information is currently still being is under stabilization process. So we were thinking of removing the previous information that was relevant in phase 1 but is not so relevant in phase 2, because now we are dealing with different scenarios. But of course, if you require this information and you are requested, we can of course share it with you, no problem. Yes, we have 1 minute. Are you gonna be giving? Oh, I understand that there are a fast test coming to the States. I want to ask you if this is included within the Sentinel model. And talking about the outbreaks in hospitals in Mexico State, in Coahuila, there's been several outbreaks. What's happening there? Is that lack of training of the staff? Is lack of equipment? What's happening? Fast testing. Let's talk about fast testing first. I have some slides about it, but we have no time today. I'll talk about it tomorrow. But let's just say, because this is a topic that has been talked about in public media. There was some information circulating that we finally accepted to use fast testing. Please do not be confused. No. The reactive stripes, which are also known as fast tests, are similar to pregnancy tests. They are devices that are quite simple and they detect antibodies against the virus. These tests, at some point, maybe we will have a more advanced knowledge of the immunological response to the virus, meaning the exact time in which the body starts to make these antibodies, and then maybe we will create a useful fast test technology for the diagnosis. But to this day, April the 8th, fast tests have no efficiency whatsoever. They have no validity whatsoever, and that's why they haven't been approved by any government international. So do not conflate these fast tests with PCR tests that are reduced time tests that require specialized equipment and specialized personnel to apply them. So PCR, there are some quicker tests, so to speak, that are still PCR, that are specialized tests, and they are the ones that were presented by the President of the United States last week. They are faster than traditional tests, but the mechanism is the same. And we actually have used them for the diagnosis of other diseases. But the fast tests that are based on detection of antibodies are not valid, and there is no recommendation in Mexico to use them. So we will continue to use the sentinel model, and in those cases that the definition of case is met, or in 100% of the chronic of the severe cases. Okay, we're out of time. We will continue this conversation tomorrow. Stay at home. Stay at home. Stay at home, please. Thank you.